Hi, friends. I am so sorry that the live ended abruptly like that. It is storming for us in Indiana, so unfortunately, our power went out and we just got it back. So I will continue where we left off and hopefully um we can catch back up. I do kind of have to see where we left off because I don't fully remember. So just give me 1 second. But I'm bringing it up.
Things that you did for her.
That's a list of different things that I did for her that day.
Okay, so you were calling.
We're just gonna pick up right here and let it finish out. They're at lunch right now, anyways. So hopefully by the time we get to when they go to lunch, we can just fast forward and we'll catch up to where they're at now. Again, I'm so sorry, guys. Our power went out. I'm so sorry, but we're back now, and here we go.
Other contacts, you were talking to Patrick, you would contact her. I mean, she certainly was not avoiding you. That's
Yes, we were in communication.
all right. You're familiar with, maybe you are, the what's called the Edinburgh scale?
I'm aware of it, yes.
And did she have the Edinburgh scale administered to her, to your knowledge?
To my knowledge, no.
Okay. What is polypharmacy? What does that mean?
Polypharmacy?
Yeah. You ever heard of that? Polypharmacy?
I've heard of it, but not sure of the exact
okay,
definition.
Okay. Is it something to do with having too much medications thrown at you all at once? If you know.
No, I'm not sure.
Not sure. Okay. Excuse me for 1 minute. Apologize. I just had something pulled up and it just went back to default on me. So I just need a second. I apologize. Okay, I get it. And how long have you been working in your particular field?
Since 2011.
Okay. And you have obviously a very impressive background as far as your educational background and your experience. Do you continue to, like, with continuing education?
Yes.
Have you ever been aware, are you aware of the Mass General Hospital Center for Women's Mental Health?
I'm aware of it, yes.
Do they offer seminars and programs as well as research articles?
I believe they do.
Okay. Do you know that Mass General Center for Women's Mental Health about a year ago issued a fairly major study and various recommendations for people that are dealing with women that have postpartum periods and how they break up the periods. You familiar with that?
No, I'm not familiar with that.
So if I suggest to you that in that particular Mass General Hospital article, it goes on about postpartum period, and do you agree that the postpartum period, 85% of women that are pregnant or after pregnancy experience some type of mood disturbance? Would you agree with that?
No, I wouldn't agree with that.
All right. Would you agree that 10 to 15% of women develop more significant symptoms of depression or anxiety?
I agree.
Okay. And then postpartum psychiatric illness is then divided into 3 categories. One sounds like something out of the 50s, postpartum blues. Would you agree with that?
Yes.
You've heard that expression before,
Correct.
right? And it can be bothersome, it can be aggravating, it can be intrusive, but it's not threatening the life of the mother or baby or anybody else, right?
Correct.
And it's fairly common, right?
Correct.
Number 2 would be postpartum depression. Now, that's a different issue, correct?
Yes.
And number 3 would be postpartum psychosis. Is that right?
Yes.
All right. Now, postpartum depression, prior to morphing, if you will, into postpartum psychosis, consists of a number of symptomology, right? For you to diagnose a woman, whether she's pregnant, has a baby, or after having the baby, with postpartum depression, there are certain things that are symptoms that you look for, right?
Correct.
Okay. One of which would be depressed or sad mood, right?
Yes.
Lindsay had that, right?
Yes.
Next would be tearfulness, right?
Yes.
Lindsay had that, right?
Correct.
Next one would be loss of interest in social activities or usual activities or friends. She had that, right?
Correct.
Feelings of guilt. She had that, right?
She didn't express feelings of guilt.
Okay. Feelings of worthlessness. Did she express that she felt worthless?
She did not express that.
How about fatigue? Did she have that?
She did not express fatigue, but lack of sleep.
I know lack of sleep. Were you aware that, in fact, that she had indicated that she was so wiped out that she couldn't even get out of bed, couldn't put her feet on the ground, and if she did, she felt heavy?
I did not hear that from her.
Okay. How about, you mentioned it, you got it, sleep disturbance is another issue, correct?
Correct.
She had that, right?
Yes.
Change in appetite. She had that, lost 10, 15 pounds, right?
Yes.
Poor concentration. She had that, right? She said she was numb. She could not focus. Suicidal thoughts.
Yes.
We know she didn't have a plan, but she had suicidal thoughts, right?
Correct.
So under the Mass General Hospital research project for women that are suffering from postpartum issues, she pretty much hit every one of the postpartum depression symptoms, correct?
Correct.
And then it talks about if it increases in severity, significant anxiety symptoms may occur. Not generalized anxiety. Significant anxiety symptoms can occur. Is that right?
Correct.
And one of the ways that you determine that is by the tests that it can be administered to a person who is in a postpartum status. And that would be what we talked about, the Edinburgh test, right?
Correct.
And you're aware that she was given the Edinburgh test and had a 23 out of 30, I think it was.
I was not aware.
Okay. And some women develop panic attacks referred to as hypochondriasis. You'd agree with that, right?
Agree with that in reference to.
Lindsay, she had panic attacks and complained of having panic attacks.
Yes.
Okay. And then you can get into the various diagnoses of which on a postpartum person in that time frame, obsessive compulsive disorder, OCD, right?
Correct.
Or bipolar 1 or bipolar 2, right?
Are you using them interchangeably or could develop?
Trust me, let's say bipolar 1.
Yeah.
Okay. So that would be one mental disease, correct?
Correct.
And it's pretty serious stuff, right?
Yes.
And if a person is diagnosed as bipolar, one of the things that you shouldn't, if you know, is prescribe SSRIs such as Prozac or Zoloft, right? If you know.
I'm not sure of that.
Okay. Would you agree that with various cases dealing with postpartum depression, all of the symptoms that we talked about, they utilize the Edinburgh Postnatal Depression Scale, which is a 10-item questionnaire that can identify women that have postpartum depression and the severity that they have. And on the scale, a score of 12 or greater it raises concern and indicates a need for more thorough evaluation, right?
Correct.
Do you know whether she was thoroughly evaluated by anybody other than Tufts and Gelada?
I'm only aware of Tufts and Gelada.
Okay. I mean, you were trying to do the best you could with what you had to work with, right?
Correct.
Okay. Now we get to postpartum psychosis. That's the third category, right? Postpartum psychosis, you'd agree, is the most severe form of postpartum psychiatric illness. Is that right?
Correct.
Would you agree that it occurs in averages about 2 out of 1,000 women, right?
Correct.
And its presentation can be very dramatic with onset of symptoms, and that can be within a year, according to the CDC, Center for Disease Control,
Yes.
right? Okay. And when it hits you, it just hits you, bang, quick, right?
Correct.
And when you think about 2 out of 1,000 people, seems like a daunting number, but if I tell you that Fenway Park, when they're full, when they're playing the Yankees, they have 37,700 people. If you take the 37,000 people and you multiply it by 2, that would mean as you're sitting there behind first base, 74 women possibly have postpartum psychosis, right?
Not sure of that number, but
Well, if you agree that it's 2 out of 1,000, according to the studies and the statistics, and if Fenway Park has 37,000 seats, times 2 would be 74.
okay.
That's a pretty large number of people, right? 74 people out of that crowd. Okay. It's not that horribly unusual. I mean, it's something that perhaps you've dealt with in your practice, right?
Yes.
And when you're dealing with people with postpartum psychosis, do you agree that generally they present with an episode of bipolar illness? If you know.
No.
No, they don't, or no, you don't know?
No, I don't know.
Okay. Bottom line is, from your dealing with Lindsay, she appeared to be sincere, right?
Correct.
She appeared to be looking for help, right?
Correct.
She appeared to be hurting, right?
Yes.
Turning in every direction she could for help, right?
Correct.
And the last time you saw her was when?
December 19th.
Okay, thank you very much.
Attorney Bucky.
Briefly, please. Ms. Dukes, you indicated that you didn't review the records of Nurse Paul or Nurse Gelada.
Correct.
Why?
I wanted to have a fresh set of eyes to look at the situation and to assess it when she came in for her visit. That's typical practice.
And that's why you do an entirely new process, right? Where you do your own intake, you assess diagnostics for determining whether there's any sort of mental illness, right?
Correct.
And while you can collaborate or speak with the providers about an overall treatment for the patient, your therapy is your therapy.
Correct.
And as far as your role, you don't have any role in medication management, do you?
No, I don't.
Okay. And so when the note read current medications, is that just based on what pre-fills for the patient, based on their historical records for the clinic?
Yes.
And so you don't know what she was prescribed and when, and if all of those prescriptions were active. You just know what's in the computer.
Correct.
And as far as the timeline here for the recommendations for partial hospitalization, I just want to make sure that we're clear. You had been for some time recommending some sort of partial hospitalization program, correct?
Correct.
And on December 12th, you had already talked to Lindsay Clancy about the Women and Infants program, had you not?
Correct.
And so when she told you on the 12th that she was starting that program in Norwell, that wasn't from your referral, right?
No.
And you still recommended Women and Infants.
Correct.
And you got her consent on that visit, right?
Yes.
And on the 19th, when you saw her, were you aware that she had been at the Mass General ER on December 15th for evaluation?
No.
And that she had reported then to them that she opted for an outpatient program at Women and Infants as opposed to going inpatient to McLean? Did you know that?
I wasn't aware of that.
Okay. And when you met with her on the 19th, after the visit to the ER, she still hadn't engaged with Women and Infants, had she?
No.
And so you had to re-refer her.
Yes.
But you weren't aware that she had already gotten a referral from Mass General.
No.
And so you did later learn she went on December 20th, correct?
Correct.
And were you able to review those records about this visit to the 20th? So you don't know that the ultimate plan and assessment for her was that they didn't think she qualified for the program, but they provided her with several options for other inpatient treatments for medication management, partial hospitalization, and general mental health. Did you know that?
No.
And as of your last meeting with her on December 19th, ultimately, what were your impressions of how she was doing?
My impression was that her symptoms were improving because of the social aspects, spending time with family and friends and able to exercise when before it was difficult for her to engage or pay attention.
And your observations of her while you were interacting with her, were they more positive than on previous occasions?
Yes, she was able to smile and laugh.
Okay, thank you.
What were you laughing about? When was it she was laughing with you?
I believe that was the last visit, the 19th.
So on the 19th, it was on television or was it in person?
It was a virtual visit, a video
Virtual
visit.
visit.
Yes.
And on the 19th, on the virtual visit, what was the purpose of that visit?
The purpose of that visit was to see if she was able to connect with care.
Okay. So you would have, I guess, in your notes or reference to the fact that on the 19th of December that she was laughing.
Not that she was laughing, but that she was able to laugh.
Able to laugh.
Yeah.
Okay, because I'm looking here on December 19th, telemedicine. Letitia, I apologize, Dukes, perinatal behavior health program. And you talk in that form about the date of the service, December 19th, psychotherapy, PCP, Margaret, that would be the primary care, Margaret Anastasia. Perinatal behavioral health program. You talk with the quote, if this is telehealth visit, please dot the phrase video visit, whatever. Therapeutic intervention. She's 32 years old, married, female, presents for postpartum anxiety. Symptom management. Patient continues to have low mood and numbness. Numbness. Was she laughing when she had numbness?
What date are you looking at?
December 19th, the last day you saw her, or the last time you had any contact with her.
She didn't appear to have that, no.
She didn't appear to have what, laughing or numbness?
Numbness.
Well, it says right in the notes, does it not, that the patient continues to have low mood and numbness.
Yes.
Okay. I don't want you to say yes unless I can show it to you. So, patient continues to have low mood and numbness, right?
Correct.
Patient has not had suicidal ideation and did not need crisis intervention over the weekend. In other words, she didn't kill herself, right?
Correct.
To help with the mood, patient has been spending time with her husband, children, and exercising, right?
Yes.
And exercise. is one of the things that you would generally, your people would generally recommend that the mother do, right?
Correct.
That's a good thing to try to do, is to exercise, right?
Correct.
So the fact that the government has records that show that she would take her kids or her husband would take her kids, or they would go to a local gym and exercise or swim, that's consistent with what she was advised, right?
Correct.
It doesn't mean that she's just out there having a good time exercising, right?
Objection.
No, overall.
She was told that that's a good thing to do, right?
She was told that that was a good thing to do, but the fact that she's able to follow through and do it shows improvement.
Oh, okay. So when did she go to the gym?
She didn't give me exact dates. These are things that
Did
she
you ever
told me
ask
she
her?
did.
Did you ever ask her, if you're telling me that, this is showing improvement, is it in the records? Does it indicate that you asked her if she was exercising, and if so, where and when?
So we don't write down everything that we talk about in the meeting. It's particularly a summary of that visit.
Okay. And all I did was ask you about the patient was spending time with her husband, children, and exercising, and then you said that that's an indication that she's improving.
Correct.
Okay. And then I asked you if she's going to a gym. That's not a bad thing, is it?
No, it's not.
Okay. And then it says that she received a call, and counsel asked you about this. She received a call from women and infants, but missed the call. Do you remember that? Remember the DA asking you that question? You said that she missed the call.
Yes.
She didn't continue to read that the reason she missed the call is that she was at another medical appointment, right?
Correct.
And she called you back, right?
Yeah.
Okay. Clinician, you provided contact information for women and infants. Patient reported that she would contact them today, being December 19th, but in fact, she did, and you did back it up. She did with your help, and she then went the following day on the 20th, right?
Correct.
Okay. And finally, fair to say that nowhere in here does it say that she was laughing?
You would have to go to the assessment, the risk assessment.
Okay, let's do that. Got it? Let me see, please. Okay. Now, what's a mental status exam?
So a mental status exam is to assess how the person is appearing that day, their mood and their interaction with you in that visit and how you perceive them.
Okay. So, with the help from the DA, we have December 19th, the telemedicine form, clinical notes, right?
Yes.
The laughing wouldn't be in that area, would it?
No, it would be more so in this area.
Yeah, okay.
Yes.
Mental status exam, right?
Mm-hmm.
Appearance, hygiene, WNL.
Within normal limits.
Okay. Clothing normal, eye contact normal, build normal, posture normal, body movement normal, right?
Yes.
Behavior is cooperative, right?
Yes.
And speech is within normal limits, is that correct?
Correct.
Emotional state, affect. Patient reports feeling numb and having low mood for most of the day, right?
Yes.
Facial expression, other. Facial expression, calm, was able to laugh and smile, right?
Yes.
Would that be in response to you saying something funny, or why was she laughing?
That would be in response to me saying something funny.
So you guys were kind of bonding a little bit.
Yes.
All right. But she basically still continued to report that she was numb, having low mood, and basically the symptomology that she had already reported, right?
Correct.
Okay. Thank you, ma'am. I appreciate it.
All right, Como.
Nothing further, thank you.
All right, thank you. Thank you. You may step down. Thank you. All right, Como, do you want to call your next witness?
Come on, also call Cameron Daly as its next witness, please.
Good afternoon. Do you solemnly swear that the testimony and the evidence you shall give to the court and the jury in the matter now pending between the Commonwealth and the defendant shall be the truth, the whole truth, so help you God? Thank you, sir. You may have a seat.
All right, good afternoon, sir.
Afternoon, Your Honor.
All right, Ms. Buckingham, please.
Thank you. Sir, could you please tell the jury your first and last name?
Cameron Daly,
And how do you spell your first name?
Cameron.
And can you just spell your last name for the record?
Daley.
And where do you work?
Duxbury Police Department.
How long have you been there?
6.5 years.
And back in January of 2023, what was your assignment then?
Patrolman.
And I'm going to draw your attention specifically to January 24th, 2023. Were you asked to do a particular assignment out of Duxbury in that evening?
Yes.
And what were you asked to do?
Report to Brigham and Women's Hospital
And why were you going there?
for hospital watch of the suspect.
And that individual was Lindsay Clancy?
Correct.
Was there already a Duxbury officer on scene at Brigham and Women's when you got there?
Yes, 2.
2?
Yes.
And who were they?
Officer Lepard and Officer Broderick.
And when you arrived at the Brigham and Women's Hospital, were you by yourself or was there somebody else with you?
I was with another officer, Officer Thomas Johnson.
Okay. And were you able to make observations of the suspect, of the defendant, Lindsay Clancy, on that day?
Yes.
And she was asleep, was she not?
Correct.
And she had medical devices attached to her?
Yes.
Was she being treated by the medical staff there at Brigham?
Yes, periodically.
Okay. And were you inside or outside the room, if you know?
Outside the room.
And were any visitors or any other people other than the medical staff in that room with her while you were there?
No.
And from the 24th into the 25th, what time did you leave the next day on the 25th?
So I reported to the hospital on the 25th.
Oh, okay.
I was there. I arrived at 10 a.m.
So your shift there at the hospital was what?
I got there at 10 a.m. I left about 7 p.m. that night, but it was an 8 to 4 scheduled patrol shift.
Okay, and you said that was on the 25th.
Correct.
And you took over for Officer Lepard.
Correct. Who were there on the overnight previous.
Okay, thank you for clarifying. And when you left that next evening on the 25th at 7 p.m., was there another Duxbury officer who came to relieve you, or who came to relieve you?
No, at that time, State Police Detective McDonald arrived on scene with his crime scene team, and then Plymouth County Sheriff deputies came to take over the hospital watch.
And during that entire shift that you were there, were any attorneys or any other individuals in the room to see Ms. Clancy?
No.
And did you go back to the hospital for any shifts after that day?
No.
Thank you. Nothing further.
Were you in uniform?
Yes.
Had your gun on?
Correct.
Had your badge?
Yes, sir.
The other guy too?
Yes, sir.
You were gonna what, guard the woman that was tied to the bed?
Correct.
That's all we have.
Anything?
Nothing further.
All right, thank you, sir. Please step down.
Thank you.
All right. So members of the jury, rather than start another witness for just a couple of minutes, we're going to break, take the afternoon recess at this point. The plan would be to come back approximately 2 o'clock, come right back, resume with the Commonwealth's case. To remind you again, I think you probably know what I'm going to say. No talk about this case. Don't do any research about this. Don't read anything about it. While you're on break, don't go anywhere that has anything to do with this case. Take the next hour, just kind of put this out of your head. We'll see you. Okay, thank you.
Court, all right, good. Find yourself a notebook. This, focus.
right, Council Fay, just for 1 second, sidebar, just for a minute.
Every time that I saw her, and she never had mania.
All right, so this is a
Never.
Action to
as to the mental health of the mother. Let's take a listen.
Does your note say, and I quote, also discussed possibility of undiagnosed bipolar disorder given extreme reaction to SSRIs and insomnia, period? Does it say that?
Yes.
Did she have bipolar?
No.
Did you make that decision that night, that day?
I assessed that with her pretty much every time that I saw her, and she never had mania.
All right, so this is a psychiatrist. We know this is a psychiatrist. The husband is husband. He's no longer the husband, the father of the children who testified, husband at the time. He has filed a civil lawsuit against different providers and pharmaceutical companies, as I understand it. And one of them is this psychiatrist we just heard from. And so, Joanna, in saying that, no, she's not bipolar, is the onus now on the defense to have to present an expert that says, no, she was in fact bipolar? Or can they avoid that and sidestep that by instead having an expert that says she was suffering from postpartum psychosis?
So I think the real answer is that the defense does not have to prove the specific diagnosis in this case. What they're doing is creating doubt about the criminal responsibility. And I do believe another witness kind of testified that she was presenting with, symptoms that made her question whether or not there was like a underlying bipolar issue that was that should not have been or was kind of indicating with the Zoloft that was prescribed. And so even though one provider may have determined that she was not bipolar, another identified that it was a possibility. And I think that is part of creating the doubt, right? These inconsistent, fragmented analyses by various clinicians that nobody really landed on the true underlying issue.
And let me ask you your opinion about Ben Chu, who was a guest earlier on the show. He made the comment that he was really surprised in this case that there wasn't some type of plea or agreement reached not to try her for being criminally responsible, but rather ensuring that she got the mental health treatment that she needed, because we know that it doesn't mean she's going to get out tomorrow if the jury agrees. She's not criminally responsible because of mental health diagnoses. It means that she then gets treatment. And so are you surprised that in this particular case, with the facts as you've heard them to be at this point in the trial, that they weren't able to reach some kind of agreement that she gets mental health treatment?
I am not surprised, mainly because I think that's our perspective as defense attorneys. And we live in this idealistic world where we're like, we notice an issue and we want treatment for the issue or rehabilitative means or restoring somebody to competency if it's even possible. And we're looking for that kind of restorative process versus the prosecution is looking for accountability and typically takes this penalistic approach. Not in all jurisdictions, but I think here, when you're faced with such a tragic and heinous type of crime that's under such a high amount of public scrutiny, I am not surprised that the prosecution pushed this along, even if I don't necessarily agree that it may have been the best approach.
And at least at this point in the trial, I feel like both sides' narratives are plausible, right? We haven't heard all the evidence. I don't know where I'll land at the end, but I do think there's argument to be made that her being criminally responsible is equally as plausible as perhaps it was a mental health, such as the postpartum psychosis. Let's listen, though. Some of the other evidence presented by the prosecution so far in this case is from another expert. This is a nurse practitioner, Rebecca Gelada, who also testified about the mental health of the mother, Lindsay Clancy. Let's listen to that.
It means typically not something you would want to do if you were sure somebody had bipolar disorder, because if you put somebody on just an SSRI or like Prozac, like Zoloft, it can create a scenario where people are flipping back and forth between manic symptoms and depressed symptoms, or they're called rapid cycling. It's not that antidepressants or SSRIs are never prescribed in bipolar disorder, but you often would want to have a mood stabilizer on board at the same time.
And so, despite your suspicions, you listened to the patient and went along with her request.
Yes.
You know, often patients are the ones who self-report, and often patients are left with that final decision. But my question, Joanna, is how hard do you think it is for a jury to assimilate all of this information? They are drinking from a fire hose of individuals who are trained, who have expertise about medical diagnoses, names of prescriptions, what symptoms are. It is a lot of technical information medically if they're not accustomed to or know it from their everyday life that they have to really absorb to figure out what they think happened.
Yeah, you can only hope that they are taking really good notes and that ultimately they ask for readback. And if they have any questions, that they're allowed to ask questions. Various jurisdictions are different on how they allow the jurors to ask questions, whether it's during the course of the proceedings or, in deliberations. But that if they need clarity, that they will ask for it. And that, I think, is an indicator of them taking deliberations very seriously when they do look for clarification on particular points. This has been 12 days of testimony, so I would not be surprised if somebody needs a breakdown again of what the testimony was from any witnesses, especially those that are providing expertise and testimony regarding medications.
Yeah, and I think they're going to have a whole lot more of that testimony from the defense experts. We'll have to wait and see. I don't know that, but I expect that to be true. Joanna, stay with us. We want to take a break while they should be coming back from lunch. There again is a live picture of the courtroom seal. We know that they are returning from lunch break and that will get underway as soon as they are back in that courtroom with a witness. Perfect time for us to squeeze in a break. You won't miss a word. We'll be right back.
This court is back in session. You may be seated.
Your Honor, for the purpose of the record, we return back to the matter of Commonwealth versus Lindsay. Clancy, all parties are present excluding the jury.
All right, Counsel, can I see it sidebar?
Your Honor, we could just go back to
Oh,
second.
sure.
Sorry.
While we're waiting for the jury, it just kind of remind again that we've got people coming in and out at all times. I want to remind everybody of the pending media order regarding certain pieces of evidence. I also want to remind the warning that I gave, I think it was last week, that there are to be no disruptive statements or anything that's going to disrupt these proceedings. If that's done, they will be dealt with summarily, as we say. All right, so just a warning in regards to that. Okay. We all set? All right, yep. Ready for the jury.
Court, all rise. Jurors enter. This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and including the 18 jurors.
All right. Everybody, thank you for your patience. We'll give you a couple extra minutes to look at the solar eclipse while you're out there. So what we're going to do is we're going to return now to the Commonwealth's case. Commonwealth, could I call your next witness, please?
Prior to the witness, Your Honor, I would just move to enter in as the next exhibit the excerpted pages from the South Shore Health System Perinatal Behavioral Health Program regarding the last witness, Letitia Dukes.
Okay, any objection?
By agreement, Judge.
All right, so it's by agreement.
226.
We would call Nicole Bradley as the next witness, please.
Okay, thank you.
Just for the record, Your Honor, I object. It's not contested. I don't think it's necessary, so I object.
All right. Same finding.
Yes.
Good afternoon. You stop right here, raise your right hand to the clerk, please.
Good afternoon. Do you solemnly swear that the testimony and the evidence you shall give to the truth and the jury in the matter now pending between the Commonwealth and the defendant shall be the truth, the whole truth, and nothing but the truth, so help you God? I do. Thank you. You may have a seat.
Watch your step, please.
Hi, good afternoon.
Good afternoon, how are you?
Good, thanks. Just going to ask you to keep your voice up so the jury can hear you and speak into that microphone, okay?
Okay.
Thank you. Yes, come on.
Thank you. Could you please tell the jury your first and last name?
Yeah, Nicole Bradley,
And where do you work?
Plymouth County Sheriff's Department.
What do you do there?
I'm an Assistant Deputy Superintendent of the Field Services Division.
And as one of the roles of the Field Services Division, does the Sheriff's Department engage in what's called hospital watch?
Yes, we do.
Can you tell us very briefly what that is?
Yep. So if any safekeep, detainee, or inmate goes over to the hospital, we use our deputies and matrons to cover them on a security watch.
And are the employees from the Sheriff's Department who are on those watches required to log the activity of who comes and goes from the individuals who they are there to watch?
Yes, they are.
And are those records kept in the normal course of business at the Sheriff's Department?
Yes, they are.
And you're familiar with those records and what they look like?
Yes, I am.
If I may approach?
Objection to the record.
Okay, all right. You want to approach and then?
Yes, please. Thank you.
Then there'll be no objection.
Just going to show you a packet. If you could take a quick look at that.
Yep. Yep.
And does that packet reflect the hospital logs that are kept by the Sheriff's Department?
Yes, they are.
And you're familiar that between January 25th, 2023 and February 3rd of 2023, that the Sheriff's Department engaged in hospital watch on a patient by the name of Lindsay Clancy.
Yes, I am.
Would move to admit
All right,
this as
those may be admitted.
227.
no further questions. Thank you.
Ms. Reddington?
No, thank you.
All right, thank you, man. Thank you.
Thank you very much.
Commonwealth calls Dr. Renee Stonebridge.
Same objection as decided by a judge. It's not contested. It's not necessary.
All right, same finding, same analysis. Thank you.
Good afternoon, ma'am.
Good afternoon.
Can you stop right there? Raise your right hand to the clerk, please.
Good afternoon. Do you solemnly swear that the testimony and the evidence you shall give to the court and the jury in the matter now pending between the Commonwealth and the defendant shall be the whole truth, and nothing but the truth, so help you God? I do. Thank you. You may have a seat. Thank you.
Watch your step, please.
Good afternoon.
Good afternoon.
All right, Ms. Sprague?
Thank you, Your Honor. Good afternoon. Can you please state and spell your name for the record?
Yes, my name is Renee Stonebridge, Renee Stonebridge.
Where do you work?
I work at the Commonwealth of Massachusetts at the Boston office.
And what department do you work for?
I work for the Chief Medical Examiner's office.
And how long have you worked there?
I have worked there since July of 2017.
And can you describe your educational background?
Yes, I did 4 years of college at SUNY at Stony Brook in New York. I was a double major in German languages and literature and biology. And then I did 4 years at the American University of Antigua, where I got my medical degree. I also graduated with honors, magna cum laude. After that, I did a 4-year combined anatomic and clinical pathology residency program at NYU Winthrop Hospital in Long Island, New York. I also served as chief resident during my final year there, so 2016 to 2017. After that, I did a 1-year forensic pathology fellowship at the Boston office of the Chief Medical Examiner. And then after that, I did a 2-year neuropathology fellowship program through Brown University at Rhode Island Hospital. And I am board certified in forensic pathology, anatomic pathology, clinical pathology, and neuropathology.
What is neuropathology?
Neuropathology is the study of the brain, the dura, the eyes, and spinal cord, and muscle.
What is your role at the Office of the Chief Medical Examiner here in Massachusetts?
My role there is the Director of Cardiac and Neuropathology. I'm also a medical examiner, but my primary focus is brains and hearts.
And so will there be an occasion where a medical examiner is doing an autopsy and they will send you either a brain or eyes or things of that nature to examine?
Yes.
And why are those things sent to you in particular?
We have certain criteria that is followed in order for a neuropathology consult to occur. Some occasions are any children under the age of 2. I am to receive the brain, typically the spinal cord, depends on circumstances, the eyes and the dura as well. Also, if there's any suspicion of some type of homicidal injury to the head, blunt trauma, typically, those cases will typically come to me as well. Sometimes there are cases in which it may just be something that is a surprise. One of the MEs is doing the autopsy, the head is opened up and they see something unexpected. They see something that may be hard to diagnose as someone who is not neuropathology trained, or maybe something like a tumor that is unexpected, or a rare neurologic disease, neurodegenerative disease that requires further neuropathologic evaluation.
And were you tasked with doing some examinations regarding Cora Clancy, Dawson Clancy, and Callan Clancy?
Yes.
And specifically for Cora Clancy, what did you examine?
For Cora Clancy, I examined the eyes.
And what were your findings when you examined her eyes?
The findings when I examined the eyes were that there was acute hemorrhage of the extraocular muscles and adipose tissue. So when the eyes are taken out, this happens after the brain comes out of the skull. And there is a thin portion of bone in the bottom frontal portion of the skull where that bone is broken, and the eyes can then be examined on the inside of the head. Obviously, they're examined also on the outside of the head as well. But you can look at the optic nerve and you can look at the tissue that is surrounding the eyes. So the eyes are within the head with some muscle and some adipose tissue. So there is hemorrhage in these portions of adipose tissue and muscle that is surrounding the eye itself. And then also one of the findings was that the optic nerve sheath on the left side has some punctate hemorrhage. So the eyes, they're sitting in the head, and then there's the optic nerve that connects to the back of the eye and goes to the brain, which sends these signals so people can see. And there was some hemorrhage in this portion surrounding the nerve that connects the left eye.
And are you able to determine by seeing these hemorrhages what caused them?
Hemorrhages themselves are a very general finding. However, given the entirety of the case, knowing what I know from the autopsy findings, I can say it is consistent with something asphyxial.
And why is it that when there's something asphyxial, that means strangulation of some type, correct?
Yes, it can be.
Why is it that these types of hemorrhages occur in the eye?
What happens when there's some sort of asphyxial element to a person, it could be from many different things, but what happens is the blood in the head, if there's, say, some type of compression of the neck or something else that causes asphyxia, there's many things, but if there's some sort of compression, the blood basically gets kind of stuck in the head area. And because the blood can't flow back down through the body, what happens is there's little tiny blood vessels. They're in the eyes, they're in the skin, in the mouth, all over the head region. They basically get blocked up with this blood because it can't move. And these little blood vessels will burst, which leads to these little hemorrhages.
And in terms of Dawson Clancy, what did you examine with Dawson Clancy?
For Dawson Clancy, I examined the eyes as well.
And what were your findings?
The findings were that there was also some acute hemorrhages in these muscle and adipose tissue surrounding the eyes. And then the right eye had some small hemorrhages in the posterior retina and the optic nerve sheath. So the back of the eye, there's the retina within the eye, and the retina connects with the optic nerve at the back portion of the eye. And in this case, there was a little bit of hemorrhage at that connection point where the retina connects to the optic nerve.
And what is hemorrhage?
Hemorrhage itself is just blood that is no longer contained in a blood vessel.
So it's burst from that vessel?
Correct.
And then in terms of Callan Clancy, what did you examine with Callan Clancy?
For Callan Clancy, I examined the brain, the dura, the spinal cord, and the eyes.
And what were your findings?
The findings were that there was hypoxic ischemic changes. Essentially, that means that there has been some sort of incident which has caused the brain to have a certain period of time in which blood and oxygen flow were not appropriate. So in this case, there was a time frame in which there was no blood going to the brain, there wasn't enough oxygen going to the brain, and the brain will show certain findings in these sort of circumstances. One of the things I note is that there's edema. Edema is when the brain starts to swell. Edema is also a very general finding. It can happen in many instances, but the edema basically means that the brain starts to swell, so you don't have the nice kind of bumpy pattern on the brain. It starts to swell up and it gets a little more flattened because the brain is encased in the skull, so now it's pressing against the skull because it's swelling up and getting bigger. One of the other things I noted with that was that there was compression of the ventricles. So the ventricles are almost like a tunnel system inside the brain that allow for the cerebral spinal fluid to flow through the brain and go into the spinal cord. And when the brain starts to swell up, it not only swells up outwards, but swells inwards on itself as well. So these ventricles that are located in the inside portion of the brain are starting to get kind of squashed because the brain is swelling. Another thing I noted was that the brain was diffusely friable, meaning that it's very soft. So one of the things I do on all my brain cases is they go into formalin. The formalin allows them to fix, which basically firms up the tissue. And it makes the tissue more easy to manipulate. A fresh brain coming out of a skull is very soft. It's very easy to damage it. It's very easy to put your fingers through it if you're not careful. So one of the things that gets done is these brains will go into formalin. I typically will let them fix for about 2 weeks or so. And sometimes, regardless of the fixation time at the formalin, sometimes the brain still will not firm up the way it should, because if I'm receiving a brain and it's already has hypoxic ischemic changes, the formalin is only going to penetrate the tissue so much because the tissue is essentially already dead.
Can I just stop you for a second? What is hypoxic ischemic changes?
Hypoxic ischemic changes is when you are getting lack of blood and oxygen flow. So hypoxic is the oxygen portion and ischemic is the blood portion.
So what you saw with Callan's brain was consistent with a lack of blood and oxygen?
Correct, yes.
Which then led to brain death?
Correct, yes.
How long, based on your training and experience, does it take for a brain to start dying after the loss of blood flow and oxygen?
It varies based on different sources. Most sources say it's between about 6 to 8 minutes. If there's no oxygen flow, then the brain will essentially start dying. It depends on, if there's resuscitation that occurs afterwards, but it's generally in the frame of 6 to 8 minutes or so.
And once brain tissue dies, it can't be brought back, correct?
Correct, yes.
I have nothing further. Thank you.
You're welcome.
Rayton? All right. Hold on, Counsel, hold on. We're going to take a short break. All right. So why don't this will be a very short break. Come out, we'll come right back. Okay.
Court, all right. Jury, close the notebooks. Please come to chairs, please. This way.
we'll be in a short recess in the courtroom.
Everybody, clear the court.
All right. Counsel, can I see it sidebar?
Commonwealth versus Lindsay, Clancy.
This break has been almost 30 minutes long, by the way, and they are now going to a sidebar to probably discuss this being the end for the day and that they will be wrapping it up because they typically end around 3:30 to 4. So, I am so sorry that this has been a lot of sidebar waiting and breaks. Ooh, camera moving.
All right, George entering. This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and including the 18 jurors.
All right. Well, members of the jury, I just kind of want to revisit an instruction I've given you a couple times, I think, during the course of this trial. It's important to understand and remember that sometimes there's evidence that's presented in the trial that creates an emotional reaction. But as jurors who have taken an oath to follow the law, I'm instructing you that the law says you must separate any emotional reaction on your part from the informational value and weight that the evidence produces. Your verdict in this case is going to have to be based solely on the evidence, and it's not going to be, it cannot be based on sympathy or anger or passion or prejudice. All right, so you've got to keep that in mind. And so with this, we're going to go to the next witness. Okay.
Commonwealth calls Dr. Barbara Vidal Olson.
Same objection.
All right. Same finding and analysis.
No, ma'am. Sound like you're raising your right hand to the clerk, please.
Good afternoon. Do you solemnly swear that the testimony of the evidence you shall give before the court now coming to you the truth, the whole truth,
I do.
and nothing but the truth? You may have a seat.
Watch your step.
All right. Good afternoon, doctor.
Good afternoon.
All right. I'm going to ask you also to keep your voice up so the jury can hear you and speak into that microphone if you would.
Okay.
All right. Ms. Sprague.
Thank you, Your Honor. Good afternoon. Can you please state and spell your name for the record?
My name is Dr. Barbara Olson, B-A-R-B-A-R-A-O-L-S-O-N. I previously practiced under my maiden name, Barbara Vidal, V-I-D-A-L.
Can you describe for us your educational background, please?
I completed my undergraduate studies at the University of New Mexico. I also completed 4 years of medical school at the University of New Mexico School of Medicine. Afterwards, I came to Boston to study the field of pathology at Beth Israel Deaconess Medical Center. I completed a 4-year residency program there, studying both anatomical pathology and clinical pathology. And after my residency, I did a surgical pathology fellowship studying the gastrointestinal tract, liver, and pancreas. And I ended my training doing a fellowship of forensic pathology at the Boston office of the Office of the Chief Medical Examiner. I am board certified in anatomical pathology, clinical pathology, and forensic pathology.
And what is forensic pathology?
It is essentially the study of causes that are diseases, disorders, or trauma that results in sudden, unexpected, or non-natural deaths.
And do you currently work at the Office of the Chief Medical Examiner?
Yes, I'm a medical examiner at the Cape Cod office of the Office of the Chief Medical Examiner.
How long have you worked there?
Since 2021.
And approximately how many autopsies have you performed?
I have examined over 1,900 bodies and performed over 800 autopsies.
And when performing an autopsy, is there a specific process or procedure that you follow?
Yes, so an autopsy is composed of many parts. The first part being documentation review, and the second part being the examination of the body, which is broken up into two parts. The first part being the external examination, where I look for identifying characteristics of a decedent, such as eye color or hair color. I also look for any evidence of natural disease or trauma on the outside of the body. And the second part is the internal examination, where I create a Y-like incision on the chest and abdomen and examine the soft tissues, bones, and organs, looking for any evidence of natural disease and trauma. I also examine the brain.
And did you perform an autopsy on Cora Clancy on January 25th, 2023?
Yes.
And did you follow that same process with Cora Clancy?
Yes.
And so that started with a document review, is that correct?
Yes.
And what type of documents are you reviewing when you do that?
Typically, I have a preliminary police report to review, as well as either EMS records or records from the emergency department.
And did you start with an external examination of Cora?
Yes.
And what did you observe during that external examination?
The external examination of Cora, I saw evidence of medical intervention. She was intubated, had various EKG pads and defibrillator pads on her body. She also had a catheter on her right hand and puncture sites on her left hand and her left groin. She had her neck stabilized with a cervical collar, and she had an intraosseous catheter, which is a type of IV they put directly into the bone on her right lower leg. Her hands at the time of my external examination were covered by police evidence bags, and they were secured at the wrist with tape. When I removed those, the fingers showed no evidence of injury, and the fingernails were all of equal length and intact. And then I noted evidence of trauma of the neck with associated injuries of her head and minor injuries of her right arm and of her legs as well.
And in terms of the injuries that you observed, evidence of trauma to her neck, were there also injuries to her face and neck area that seemed to go along with the trauma to her neck?
Yes, there were findings of the head that were associated with the trauma of the neck.
And what were those?
So on her neck, she had a ligature furrow. A ligature is an object used to apply external force to the neck or compress the neck. And a furrow is simply the pattern of injury that develops underneath the site of compression. So for Cora, her ligature furrow consisted of a linear, horizontally oriented area of pallor or paleness around her neck with distinct superior and inferior edges. On the front part of her neck, the lower half of the ligature furrow was associated with additional red abrasions ranging from 1 to 2 millimeters in size. And on the back of her neck, the superior and inferior edges of the ligature furrow had developed some linear bruising as well.
And what do you mean by a furrow?
So again, the furrow is a ligature is when you have external compression by an object on the neck, and a furrow is simply a pattern of injury that occurs beneath it. It can be an imprint, it could be a pattern, or it could be more developed types of injuries such as bruising or abrasions.
And what about injuries?
All right, Council, we're going to take a break this time, all right?
All right. Jurors, close your notebooks. Place them on the chairs, please. This way, please.
Recess for a few minutes. I'm going to come back. We'll speak to council in regards to schedule. Okay. Thank you.
Court succession, please be seated.
Your Honor, for the purpose of the record, we return back to the matter of Commonwealth versus Lindsay, Clancy. All parties are present, excluding the jury.
All right. Counsel Sidebar, please. Yeah. All set.
Yes, I am still under oath.
Court, all rise. Jury. seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Clancy. All parties are present, including the defendant and the 18 jurors.
All right, Attorney Sprague?
Thank you, Your Honor. You had described previously the injuries to Cora's neck. Were there also injuries on her face that correlated to those marks?
Yes. On examination of her face, she showed diffuse petechial hemorrhages of the skin of the face, most prominently around the skin of the eyes. She showed petechial hemorrhages on the inside of her eyelids as well as the inside of her lips.
And if I could have photo 2246, please. Doctor, there's a remote here. If you press and hold the top button, you can highlight what you're talking about in the photo when it comes up. What are we seeing here? Is that the area of the petechial hemorrhage?
Yes, in this photo, I have the lower lip pulled down, and on the inside of the lower lip, we can see punctate hemorrhages, which are the petechial hemorrhages.
Okay, and if you could, is that working for you? I can need to see that. There we go. Okay. This area here?
Yes.
Okay. You just hold that top button and hold it down. And so we can remove that photo. When you talked about petechial hemorrhage in the eyes and eyelids, did it look similar to that?
Yes.
And basically it's those red marks all around the mouth, and then those same red marks were on the eyes.
Yes.
Eyelids, you tell me where they were.
So they are pinpoint hemorrhages that occur. And again, they were located on the inside of the eyelids. So I inverted the eyelids and I flipped open the inside of the lips, and they were also in those locations.
And if we could have photo of 7784, please. If you could tell us what injuries we're seeing here in this photo.
In this photo, we are looking at the body from the left, and you can see the ligature furrow in this photo. Here is the linear area of pallor with the distinct superior and inferior edge. You can also appreciate in this photo some small punctate hemorrhages or the petechial hemorrhages of the face.
Okay. And if you could show photo 7782, please. What are we seeing here in terms of injuries?
In this photo, we are looking at the front of the neck, again focused on the ligature furrow, which is this distinct area, linear area of pallor. And on the front of her neck, the lower half of this ligature furrow had scattered red abrasions associated with it.
You can take down the photo. What are abrasions in terms of what you do?
So abrasion occurs when there is sufficient friction against the skin to cause a removal of the superficial layer of the skin.
Is it basically a scrape?
Yes.
And can we have photo 2256, please? You can tell us what we're looking at here, please.
This is a close-up photo of the back of the neck. Here is the linear area of pallor with the distinct superior and inferior linear edges. You can appreciate that the linear edges in this photo started to develop linear bruising.
And were there other injuries on the body other than those on the neck and the face?
Yes, she had injuries to her right arm and on her legs.
And if I could show you photograph 7789. Are you able to tell us what we're looking at here?
This is an up-close photo where we can see a very small, faint bruise. All of the bruises on her legs as well as her right arm consisted of small scattered bruises.
And if we could have photo 7770. What are we seeing here?
This is an image focused on her right leg. Here we see 3 bruises on her knee and 2 bruises on her left lower leg. This is a site of medical intervention, the intraosseous catheter site where the needle enters the bone.
And if we could see 7790, please. What are we seeing here?
This is a close-up photo of her left leg. Again, we can see a bruise here as well as a bruise here on her left lower leg.
And then the last photo, 2233. I'm sorry, one more after that. What are we seeing here in this photograph?
In this photo, we can see the bruises I described earlier, as well as the inside of her left ankle. We're seeing 2 additional bruises.
And if we could see photograph 7794. What is shown in this photo?
This is an image of her left leg, again showing the 2 bruises close to her left ankle and then additional bruises on her left lower leg.
And then 7775, please. What are we seeing in this photo?
This is an image of her right arm extended, and I have the image focused on her right bicep where there was 3 small bruises.
And in terms of bruising, are you able to tell the age of a bruise by looking at it?
No.
Can you tell whether it's a fresh or an old bruise?
So generally speaking, we can appreciate the color of bruises. So red, blue, purple bruises tend to be bruises that occur more recently. And as they heal over time, they start to take on a yellow or green appearance.
And the bruises that you observed on Cora's body, how did they appear?
They all had versions of red appearance to their shapes.
So because they had red appearance, does that mean that they are fresh wounds?
They occurred recently.
And again, you can't tell how they occurred or what the exact time and date they occurred.
Correct.
Is there any information you can glean from the location of the wounds where some of the bruises were close together, like the 3 on the knee or the 2 on the lower right leg?
No, I can only document where they are and their measurements.
Now, can I have a moment?
Sure.
Going back to the injuries on her neck, what do those tell you based on your training and experience, when you're trying to determine the cause of death? What do those wounds tell you?
When I see a ligature furrow that is horizontally oriented in association with significant petechial hemorrhages, those findings are consistent with a ligature strangulation.
And what is ligature strangulation?
Again, a ligature is an object used to apply external force to the neck, and a strangulation is when it is done by someone else.
And when that happens, what effect does it have on the body? How does it? What is the mechanism of death?
Ligature strangulation results in a category of asphyxial type of deaths. Asphyxia means that the body is deprived of oxygen, and in this case, specifically the brain. So when you have compression on the outside of the neck, blood is how oxygen is delivered throughout our body. So the right side of the heart delivers blood to our lungs, where during breathing and respiration, we then put oxygen to our blood. It then moves to the right side of our heart and gets pushed out to our body through blood vessels we call arteries. Once the oxygen is released at its targeted site, it then recirculates to the right side of the heart through blood vessels called veins, and the process starts all over again. It's a continuous circulation. But when you have compression of the neck, first and foremost, your airways reduce, it's compressed. So you can have a reduction in your ability to breathe or complete inhibition in your ability to breathe. When you have compressions of the veins of the neck, the blood cannot drain from the head. And so then the blood actually has a backwards flow of pressure that meets the arterial blood. And that results in an increase of blood pressure within the blood vessels, as well as an overall increase in intracranial pressure. And with the compression of the artery, there's no oxygenated blood being delivered to the brain.
And as this blood is gathering in the face and head area, is that kind of causing the same type of pressure as a balloon filling up?
Yes, or like a water pipe as well.
Okay. And what happens as that blood pools and causes that pressure in the face and the head?
What normally happens is first and foremost, the brain just has a reduced ability to take in oxygen. And in the smallest vessels in the face and brain, such as capillaries or venules, they are subject to rupture.
And as that pressure is building in those veins and are rupturing, is that painful?
Just like our blood vessels run throughout all of our body, there are nerves throughout all of our body as well. And so there is a component of pain present until loss of consciousness occurs.
And how long can it take, or does it take, for loss of consciousness to happen?
I cannot put a specific time on it for the interval. There's multiple variables to consider in a case-by-case basis. The type of ligature used, the force of the ligature used against the neck, as well as the intensity and duration of the altercation. However, in situations where there's complete oxygen deprivation, loss of consciousness can occur as early as 10 to 30 seconds, with brain damage beginning at the 1 minute mark and irreversible brain damage and subsequent death occurring around as early as 5 minutes, again with the caveat that there are variables that might accelerate or decelerate that time frame.
Is there a type of constant pressure that's required to cause that loss of consciousness?
Ultimately, once the brain has a critically low level of oxygen, a loss of consciousness will occur. It takes an average of 4 pounds to compress the veins of the neck and an average of around 10 pounds to compress the arteries of the neck.
And so if someone's squeezing something or pulling something around the neck at that 4 pounds or 10 pounds of pressure in a consistent basis without any resistance, does unconsciousness happen faster?
It could occur faster, yes.
What if someone's resisting or struggling or pulling away? Could that take longer?
When the body is in a state of stress, you have a stress response that demands an actual increase in oxygen utilization by our body. So in the presence of an increased demand with a decreased amount being delivered to the brain, it can accelerate the timeline to loss of consciousness.
What do you mean by accelerate the time to loss of consciousness?
No, overall, you can ask.
It would just make it occur faster.
And so if that pressure isn't constant, say someone struggles and is able to get free a little bit, and then you have to tighten it again, does that make it take longer?
Sustained.
You said anywhere from 5 to 30 seconds. What are the factors? I'm sorry, you said 10 to 30 seconds. Is that correct?
Yes, for loss of consciousness.
What are the factors that are at play for whether it's 10 seconds or 30 seconds?
Again, there's multiple variables. The force of the ligature against the neck, the actual ligature itself, and the intensity and duration of the altercation.
And once someone loses consciousness, do they immediately die?
No. So if there's no intervention, the brain continues to have a lack of oxygen. And so until the brain cells start to die, it's irreversible injury to the brain. The person is alive until the body can no longer sustain the lack of oxygen.
If someone is strangled to the point of unconsciousness and the strangulation stops, can they wake up?
Without intervention is very unlikely.
So do you recall testifying previously that when asked if a person were to use a ligature around someone's neck to the point where they pass out?
Counsel, we had that answer, right?
It's an inconsistent statement.
This is your witness.
I know, and I can impeach with an inconsistent statement.
I see it's sidebar.
Doctor, do you have to continue to strangle someone past the 30 seconds to cause death?
No. Once the brain is subject to oxygen deprivation and brain cells start to die, it's irreversible. And so it will continue to progress towards death if there's no intervention.
What do you mean by intervention?
Resuscitative efforts, if somebody tried to give CPR, if they were hooked up to oxygen machines.
Do you recall testifying previously that it would be your opinion that pressure would need to be continually applied even after losing consciousness to cause death?
Sustained. Hold on. Sustained. Next question.
So your testimony is that you can strangle someone for 30 seconds, let go, and then they die?
I said that in this presence of complete oxygen deprivation, there is a general time frame. And so 30 seconds, I cannot give a specific number to that. Once strangulation occurs, again, the brain starts to be subjected to a lack of oxygen. So whether the ligature is present or whether the ligature is not present, the oxygen deprivation and irreversible brain damage is already occurring.
And there's no coming back from that?
Not without intervention. It's very unlikely. Again, the brain cannot heal those cells.
Did you form an opinion to a reasonable degree of professional certainty, to medical certainty, as the cause of death of Cora?
Yes.
And what was that?
Asphyxia.
And was that by manual strangulation?
By strangulation.
Mechanical strangulation, I mean. Yes. Did you also examine or do an autopsy on Dawson Clancy?
Yes.
And when was that?
January 25th.
And did you observe injuries on Dawson Clancy when you did the external examination?
I did observe injuries to Dawson. He had trauma to his neck with associated injuries of the head, as well as minor injuries to his left arm and his legs.
And if we could pull up photo 2166. What are we seeing in this photo?
This photo is a picture of the lower lip of Dawson being pulled down, and we can see, again, similar to Cora, these petechial hemorrhages on the inside of the mouth.
And can you also see them on the eyes in this photo?
You can see periorbital petechial hemorrhages, so the skin around the eye.
And were there also those same type of hemorrhages when you lifted the eyelid?
Yes.
And if we could have photo 2149. What are we seeing here?
Dawson on his neck, similar to Cora, had a linear horizontally oriented ligature furrow consisting of an area of pallor around the neck. He had distinct superior and inferior edges to his furrow as well. This is on the back side of the neck, where we can also appreciate abrasions that are in line or parallel with the inferior and superior edges of the furrow.
And if we could have photo 2147, please. What are we seeing in this photograph?
In this photograph, we can appreciate the distinct area of pallor here on the neck, again representing the ligature furrow with diffuse petechial hemorrhages of the skin of the face.
And what are we seeing there on his shoulder?
This is just some dried body fluid.
And if we could see photo 2151, please. What is depicted in this photograph?
This is a similar photograph to the one just shown here, where you can see the distinct area of pallor representing the ligature furrow with superior and inferior edges, and again, the diffuse petechial hemorrhages of the face.
And these photos of Dawson's face, the petechial hemorrhaging on the face, appear to be darker than those and more expansive than those on Cora's face, correct?
They appear more prominent in Dawson than in Cora, yes.
And what can cause the damage being more prominent and more dispersed over the face?
Again, petechial hemorrhages occur as a result of rupturing of small vessels in the skin. And so the fact that there are more present in Dawson is indicative that there were moments where some blood did reach or push through the furrow or the ligature in little spikes or peaks, which would just result in momentary increases in blood pressure that would result in more petechial hemorrhages.
And what would cause that blood being able to flow?
Any movement against the carotid arteries. The carotid arteries are thicker and more muscular than the veins, so they're more likely to push through with the blood. So that could be movement of the ligature or movement of the person handling the ligature or movement of Dawson himself.
So it could be from Dawson struggling, or it could be from more pressure or force of the ligature?
Yes, changes in the pressure of the ligature.
And if I could see photo 2143, please. What are we seeing in this photo?
This is the back of his left forearm. It is a little pale with the light, but there were 3 small bruises on the back of his left forearm.
And going to photo 2155. What are we seeing in this photo?
This is a picture of us. So at this point position, Dawson is face down. So we're looking at the side of his right leg, and we can see a small faint bruise here.
And then going to photo 2144. What are we seeing in this photograph?
This is an up-close photograph, but I can appreciate that there are small bruises in the center of the image.
And photograph 2156. What are we seeing in this photograph?
In this photograph, we're looking at the back of the legs. The one closest to us is the left leg. The one farthest from us is the right. You can see bruises here, here, and here, as well as the inside of the right knee.
And so when you said here, here, and here, that was the outer portion
of the left upper leg.
Thank you. We could have photo 2119, please. What is depicted in this photograph?
This is an up-close photo of his hands.
And is there any significance to the blueness of the fingernails?
I would not have called these necessarily blue or cyanotic. That would be more of the discoloration of his face. There is some subtle blueness to the nail beds, which is again a sign of cyanosis, which is just reflective of a decrease in oxygen in the body.
And last photo is the PDF, please. What are we seeing here?
This image, Dawson is face up, and we can see his right and left legs. Here on his right lower leg, we see small bruises. On his right knee, left knee, we are seeing a bruise. And here is a site of medical intervention, the intraosseous catheter site.
And what are you able to tell us about the bruises on Dawson in terms of whether they're fresh or old?
They were all red and purple in appearance, so they were more recent.
And based on your examination of Dawson, were you able to determine a cause of death?
Yes.
And did you determine that to a reasonable degree of medical certainty?
Yes.
And what was that?
Asphyxia.
Your Honor, I'd move to submit the original photos of Cora and Dawson as for identification, and the other, the ones that were just shown to the jury as exhibits.
So mark the first set for identification.
Exhibits N and O for identification.
All right. Then over the defendant's objection, using the same analysis as stated in the sidebar, those other photographs may be admitted.
The photos of Cora and then Dawson as the next exhibits, please.
It's 228 and 229.
And then the, excuse me, that certificate of Cora Marie Clancy as the next exhibit.
I have no objection to that.
All right. That may be admitted.
And the that certificate of Dawson William Clancy as the next exhibit. And nothing further, thank you.
Is there anything?
No, thank you.
All right. Thank you, Doctor. You may step down.
Thank you, Your Honor.
All right. Members of the jury, we're going to break at this time. I'm going to ask you to come back tomorrow at 9 o'clock. I would expect the schedule similar to what we had today. I'm going to remind you again, don't talk about this case. Don't read about this case. Don't read about any similar cases. Don't watch anything. Don't do any research. Put this out of your head for tomorrow morning. All right? and I'll see everybody tomorrow morning. Thank you so much.
All right. Good. Close the notebooks, place them on your chairs, please. This way, please.
Joseph, thanks for calling this closing session.
Council, anything we need to address before tomorrow morning?
No, thank you.
So we'll be in recess on this matter till tomorrow at 9 o'clock. Thank you.
Court stands in recess. Please exit the courtroom.
And says, I can't do this.
Okay, everybody, that is all I have for you tonight. We will be back in the morning. I will try to make sure that the power is all good and that we don't have as many problems tomorrow. But no promises. It's supposed to storm for the rest of the week into the following week. So I hope all of you have a good night and stay safe. Good night.